This breakout session is medication management. So if you're not in the right room, you might want to change. Please be sure and fill out the evaluation and turn that in before you leave. The medication management program is going to be presented by Dr. John Goudreau. Dr. Goudreau is an associate professor, Department of Neurology and Ophthalmology, and Department of Pharmacology and Toxicology at Michigan State University School of Human Medicine and School of Osteopathic Medicine. He is the Director of Translational Neurobiology Research Unit, the Director of the Movement Disorder Clinic, and has been an active member in the Michigan Parkinson Foundation on the Professional Advisory Board since 2003. Dr. Goudreau received his DO PhD at Michigan State University in Pharmacology and Toxicology and Neuroscience. He is a board-certified neurologist joining the faculty of Michigan State University College of Osteopathic Medicine in 2002. He completed his residency training in neurology at Mayo Clinic and was given the Mayo Brothers Distinguished Fellowship Award in 2000 to study movement disorders. His research focuses on genetic and environmental factors involved in the pathogenesis of neurodegenerative disorders, and he is active in education and clinical care as well. Please welcome Dr. Goudreau.
So I'm going to have to turn off this mic here. Mic. Good. So that's working. So I can move around a little bit. I hurt my back on Saturday, so if I start gimping around, that's why I was lifting my 13-year-old son up into a tree. Don't ask me why I was doing that, but I was doing that. And it's a delight to see everybody here. This is such a fantastic turnout, and we hope that these sessions are helpful for you and provide some value, as well as the opportunity to interact with one another, and that's always the fun part about this. Much like the topic that I was given this morning to cover, they gave me a topic to cover this morning in 10 minutes that would normally take me over an hour to cover. This is pretty similar. Medication management of Parkinson's disease is a very broad topic, but we'll try to focus it down on a few areas that are treatment issues that are common to all people that are living with Parkinson's disease. I have some objectives listed here, and the first one is to describe issues that we commonly face in managing Parkinson's disease. And then towards the end, we'll talk about how does hospitalization impact management of Parkinson's disease, and if there's anything we can do about that. And throughout all of this, we're going to talk a little bit about how patients can work with their physicians. And the best way patients and caregivers can work with their physicians is to understand a bit about the pharmacology of the medications that are being employed. That makes you a better consumer, a more informed patient, and you can help advise your doctor, and then makes it easier for them to make effective treatment decisions for you. I do receive research support from a variety of different areas, including some pharmaceutical companies, as well as the Speakers Bureau for Teva. So let's first talk about treatment issues that patients face in Parkinson's disease early on, shortly after the diagnosis. So these are things that come up, and I'm going to focus on medication treatment issues. We're not going to talk about deep brain stimulation or any neuroprotective therapies. These are all therapies that are designed to address the symptoms that are at hand. So these three questions are all related and are commonly asked in one way, shape, or form of me. When should I start a symptomatic medication to control my symptoms? Is there any medications I can start now that can prevent the disease from getting worse in the future? And then correlated to that is, should I wait to start treatment and reserve this effective treatment for when I really need it? Or can I save up my responses later on for when the disease is much worse than it is now? So I'll give you the answers to some of these, but we'll talk a bit more as we go along. So when should you start a symptomatic medication? Well, this is my goal, is to keep people doing things in the mainstream of their life for as long as possible. People that are engaged physically, socially, spiritually with the world around them are the people that do the best long term. So if you stay connected in your normal fashion with the world around you, that's what I'm going to seek to do. And if you're telling me anything that leads me to believe you're withdrawing from connections that you're making in your environment around you, I'm going to suggest that you start a symptomatic treatment. Conversely, if you're doing everything that you normally do and you really have no limitations and your spouse made you come in to see the doctor because your non-dominant hand had a tremor in it and it's not really keeping you from doing anything, we may not elect to start a symptomatic treatment in that circumstance. Do any medications that we know of prevent the symptoms from worsening? And I touched a bit on this morning. This is the idea of disease modifying or symptomatic or therapies that slow down the progression of the disease. And we have none that are proven with certainty. Now, there's some drugs that may have a suggestion that they may slow down the progression, but try to be reassured that if you don't start a symptomatic medication, as far as we know, you're not missing the boat on something that would have been a benefit to you longer term if you didn't start it earlier. Now, should that change in the future, then my talk will change. And finally, this is a common one that I encounter, is this idea of the magic bank. I can save up my responses to medication till later on when I really need it. Well, unfortunately, it doesn't really work that way. Your responses to medication are really a function of how severe your disease is and how long you've had the disease. And actually, early on, you have the best responses and the most sustained and robust responses to medication. As the disease progresses, the medications become a little bit more finicky and less reliable and cause more side effects. And you can't change that by delaying or waiting to start medication. So there's no reason to delay or start medications thinking that they're going to be more effective later on. The disease doesn't, unfortunately, work that way. So delaying treatment also often results in reduced quality of life. And let me show you an example of that. So this was a study that looked at a questionnaire given to patients that looked at a variety of different quality of life issues. And in this measurement of quality of life, lower scores means better quality of life, and higher scores means worse quality of life. And they compared patients that remained free of symptomatic drug. We call those drug-naive patients. Those are the people that were waiting to start treatment, compared to those people that started on a single drug to manage the symptoms that they had in early Parkinson's disease. And you can see pretty clearly the people that were delaying treatment, their quality of life over 0, 9, 18 months gradually got worse while they were off treatment. So your quality of life will suffer if you wait to start symptomatic treatment. So if you're starting to disconnect from things, it's going to only get worse if you don't start something. So please, the take-home message here, don't delay starting medication thinking you can save something up for later on. It just doesn't work that way, and then you're doing yourself a disadvantage by doing so. So if you choose to start a medication early on in Parkinson's disease, you're faced with this list. These are the list of drugs that are FDA approved as monotherapy for initial management of Parkinson's disease. And they're arranged by class of medications. So we have monoamine oxidase inhibitors like Rasagiline or Azilec. We have carbidopa, levodopa in its variety of forms, Sinemet CR, and Parcopa, which is just an orally disintegrating tablet. A variety of different dopamine agonists, and then you have this medication called amantadine. Now, talk first about amantadine. Amantadine, I have not found that to be terribly effective and often has a lot of side effects, so I usually don't use that as a monotherapy for Parkinson's disease symptoms directly. I do use it in another context that I'll touch on later on. So I'll focus on the first three classes of medications when we're talking about initial therapy. Talk a bit about how these medications work. How many people love biochemistry? Everybody loves biochemistry, right? It's just as fun as much as this exercise class that you had yesterday, next door. But how do we make dopamine? So a lot of the motor problems or movement problems in Parkinson's disease are the loss of dopamine, abbreviated here DA or dopamine. So dopamine is made from an amino acid called tyrosine that's converted into L-dopa, and then L-dopa is converted into dopamine and packaged into these things called synaptic vesicles for release. Now when the nerve gets excited, it releases dopamine in the synaptic cleft where it diffuses across and binds to this thing called the dopamine receptor, or DAR. And then dopamine that's in the synaptic cleft has a couple of fates. It can be brought back into the nerve terminal through the dopamine transporter, and then it can be cycled for release, or it can be metabolized by monoamine oxidase B. Now we can replace dopamine that's being lost in Parkinson's disease a couple of different ways. If you think about increasing the synthesis of dopamine, you can't give tyrosine This enzyme right here, tyrosine hydroxylase, is what's called a rate-limiting enzyme. So no matter how much extra tyrosine you give it, you're not going to make more L-Dopa. Now, however, this enzyme here called DDC is not rate-limited, and so the more L-Dopa you give, the more dopamine you're going to make. So that's the mainstay of therapy and has been so for almost 40 years now for Parkinson's disease. This is the king of the mountain, and nothing's gotten better than Levodopa. It's a fantastically effective drug in Parkinson's disease, and I'll show you a couple slides to reinforce that. So L-Dopa is given orally. It's absorbed in the intestine, so it has to get out of the stomach and into the intestine. And then L-Dopa crosses this thing called the blood-brain barrier to get in the brain, where it gets into nerve cells and gets converted into dopamine. One of the problems if you gave L-Dopa alone, a lot of it would get chewed up by peripheral enzymes called decarboxylases in the periphery to inactive metabolites. So we combine carbidopa and levodopa always when we administer them together so that we can use less levodopa and more of it gets into the brain. Another way to replace dopamine is to bypass this whole presynaptic synthetic machinery and give a direct agonist to the dopamine receptor. Those are called dopamine receptors. There's a couple of main classes of dopamine receptors. There's dopamine D1 receptors and dopamine D2-like receptors. Most of the agonists that we have available are selective agonists for only one of those two receptors. So you're only getting half of the picture taken care of with agonists. So you might not be too surprised that we find that agonists are generally a little less effective than replacing dopamine itself. That may be one potential explanation. So why is levodopa the king of the mountain? So we talk about drugs that slow down the progression of the disease. I think this is the only drug that we know of for certain that slows down the progression of the disease from a very basic standpoint. Is it prolongs life in Parkinson's disease and prevents disability because it treats the symptoms at hand. We don't know really if it modifies the course of the disease, but this is a graph that shows people that were left untreated, not on levodopa, versus people that were treated with levodopa. And this data was collected around the time and shortly after the release of levodopa to the market in the early 1970s. So you had a whole group of patients that didn't have any levodopa, and then you had a whole bunch of people afterwards that had levodopa. So if you look at people that didn't have access to levodopa and looked at those people that reached stage 5, which is bedbound, not able to move or care for themselves, or died without treatment, how rapidly that kind of increased from 1 to 5 years, 6 to 10 years, and 11 to 15 years without the use of levodopa. And then look what happened when we finally had levodopa available. Marked reduction in morbidity and mortality with levodopa. This is a remarkably, remarkably effective drug. Unlike almost any other thing that we see in neurology, we have such an effective drug, and that's the silver lining to the cloud of Parkinson's disease, is that we have levodopa, and levodopa can make a huge difference in lifespan, quality of life, and reducing disability. So in that sense, levodopa is our only certain neuroprotective drug. I'll show you another study. This is called the L-Dopa Study. And the L-Dopa study looked at people with the earliest, mildest forms of Parkinson's disease, and it randomized them to 4 different groups. One group took placebo, and the other groups took 150, 300, or 600 milligrams per day of levodopa, and then they were followed over time. This is a time measured up almost about a year. They were assessed with this scale called the Unified Parkinson's Disease Rating Scale. How many people are golfers? So in golf, high scores are bad, low scores are better. This is exactly the same thing. So low scores mean you're getting better. High scores mean you're not doing so well. We see that people that had early Parkinson's disease that were given levodopa, all of these people improved, and the improvement was dose dependent. The higher dose you had, the better improvement you had. Not too surprising.
I'm going to make the same request someone else did. Could you talk slower? This is a complicated subject anyway.
Sure, yeah, okay. I'll try. So they followed these people. So this is good proof that we know that levodopa improves the symptoms and that it's a dose-dependent thing. And then at the end of the study, they withdrew the medication, stopped the medication for 2 weeks, and then they reassessed people. So levodopa has a lifetime in the bloodstream of about 3 hours for most people. 2 weeks should have been sufficient amount of time for washing out all the levodopa that was in somebody's system. And look, everybody that started on their symptomatic medication early on, when you compare them to the placebo, they're all doing better than the people that took placebo along. So there may be some advantage to getting on symptomatic treatment earlier rather than later. So this is one piece of evidence that will make you think about starting medication versus not starting medication. Let's go into the nuts and bolts of levodopa. As I mentioned, these are always combined, carbidopa and levodopa. There's different ratios of carbidopa to levodopa. So 25-100 is the most common one that's used. Realize that carbidopa doesn't do anything to directly affect the Parkinson's disease symptoms. It's there to prevent side effects and to allow you to use lower doses of levodopa. It doesn't do anything directly, it doesn't even get into the brain. What you want to focus on is the levodopa part. This is how we adjust the dose of the medication, is looking at this part. That's the active ingredient, the levodopa part. And this is generic, it's been around, like I said, for 40 years. There's an older controlled release formulation of levodopa called Sinemet CR, or Sinemet ER. It should be called crummy release or erratic release because of its wide variance in bioavailability, and I'll touch on that in a bit. And then there's an orally disintegrating tablet that's useful for people that are having trouble swallowing. Behaves the same as the generic carbidopa levodopa from a pharmacology standpoint. And then there's this new formulation of carbidopa levodopa that's very clever. It's a capsule that contains a couple of different types of beads that dissolve at different rates and a powder that dissolves very rapidly. So you get a rapid release amount of levodopa, and then you get some that are released a little bit more slowly. And the idea is we want to get a strategy to make the persistence of levodopa in your bloodstream last as long as possible. Because it's a really good drug. It's only Achilles' heel is it only lasts for about 2 or 3 hours. So if we can find a way to get to last longer, then that would really improve the utility of that medication. So this Rytary medication is one approach at doing that. So how do you initiate carbidopa levodopa therapy? I almost always use the immediate release 25-100 tablet. So we start at a half a tablet 3 times a day. I advise people to take it 1 hour prior to meals. For a majority of people, taking this with a protein-containing meal will reduce the absorption. It doesn't happen for everybody, but more often than not, this is a problem. And then I advance by 1/2 tablet per dose each week, guided by a patient's response or side effects. So we increase till we get a dose that's remarkably effective. And it's not something that people often have to guess about. They can tell they're clearly better. And so I say keep going until you notice that something is obviously better. And when I look at somebody, I can't tell where they're going to fall, how much they're going to need. Usually, you end up between 1 tablet 3 times a day or 3 tablets 3 times a day. And it really has a lot to do with how well your body is at absorbing the medication rather than how severe your disease is. So don't think that, gee, I need 3 tablets 3 times a day to control my symptoms. My disease must be much worse than somebody that needs 1 tablet 3 times a day. It doesn't necessarily mean that at all. It just means that your stomach and your intestine doesn't absorb that medication very well. That's why you need more. Or it might mean the person that needs 1 tablet 3 times a day is 100 pounds and you're 270 pounds. That might be why there's a difference in the dose also. So it can vary with body weight. And then I ask patients to find if several doses are effective, choose the lowest dose. If people get up to 3 tablets 3 times a day and they have absolutely no response, they're probably not a responder to levodopa, probably don't have Parkinson's disease. So again, focus on the levodopa content, ignore carbidopa, unless you're having a lot of nausea, where we want to focus on maximizing carbidopa. The common side effects to carbidopa levodopa therapy are common to all dopamine medications. So nausea, orthostatic lightheadedness, and hallucinations are the top 3. And then this one we'll talk about later called dyskinesias. Early on in Parkinson's disease, good situation, timing is not critical at all. You can take the doses at almost any time of the day, and the medication response seems to be sustained throughout the course of the day. We call that the long duration response, and it's the golden period of time in managing Parkinson's disease because almost any medication works, and you don't have to pay that much attention to when you're taking the medication. So we gradually go up on the dose and try to find a dose that works, and I usually ask people to only make changes every week. My rule of thumb is when we're adjusting this medication, and really any medication, only make 1 medication treatment adjustment at a time. If another doctor is giving you another medication or changing something else, like an antidepressant, something for your blood pressure, this is not the time to be changing your Parkinson's medicines, because if something goes wrong, you don't know whether it's the medication that I'm giving you for your Parkinson's disease or something else. So you have to be as methodical as you can when you're starting a new medication and adjusting it. So again, doses typically range from 100 to 250 milligrams 3 to 4 times a day. There's some people that suggest limiting the dose of levodopa early on to less than 600 milligrams a day. This is based on a couple of retrospective studies, but again, I ask you to bear in mind that 600 milligrams a day means a different thing to somebody that's 270 pounds versus somebody that's 100 pounds. So I don't think this 600 milligrams a day is a magic number by any chance that makes sense from a pharmacology standpoint. But this is some of the data. that look at the risk of motor complications, and we'll talk about motor complications like off periods and dyskinesias. And this is from that Levodopa study, and they looked at the doses 150, 300, and 600 milligrams a day, and looked at wearing off, which goes higher in the highest dose group to 30%, and it goes higher when you get up to 600 for dyskinesias to up to 17%. Again, this is people that have started the medication about a year ago. So, and by within a year, if you're taking the higher doses, you're more likely to get dyskinesias in off period. There may be a lot of other explanations rather than the dose of levodopa. It might be the people that needed the higher doses of levodopa had more severe disease, and that's why they got more dyskinesias. All right, again, talk about this common thing. Levodopa, for most people, about 70 to 80% of the population, levodopa is less effective when taken with a food containing protein. Levodopa, remember, is an amino acid, and when you take levodopa with other amino acids, that's what protein is broken down to in your stomach, into amino acids. There's competition for absorption from the intestine into the bloodstream and then transported that drug up to the brain as there's competition across the blood-brain barrier as well. I don't know if you can see this, but this is a graph that shows plasma concentrations of levodopa versus time. And this dark line here with the dark circles is somebody that's taken the medication on an empty stomach. You see a nice absorption profile, and you see that again. Levodopa lasts about 2 or 3 hours. These are hours down here in the bloodstream. Same person takes the same dose here, but washes it down with 60 milligrams of milk protein. So basically, they took the drug with a glass of milk, and you can see what happened to the absorption of the medication. Almost completely obliterated the absorption of the medication. So if you're having trouble with the medication not working, this might be one explanation. If you're dosing your levodopa too close to a meal that has a lot of protein in it. Now, please don't cut protein out of your diet. I had one patient that did that, got the wrong message, and went home and eliminated protein from his diet. We didn't see him back for 4 months, and he came back, and he had lost like 30 pounds and was extremely weak. And he was just eating cereals and grains and fruit. He had cut protein out of his diet, and that's not the thing to do. You need protein. You just have to separate it from when you take the medication. I can take a few questions, but if I answer a lot of them, then we won't ever get done. But go ahead. Right, that's a good. So again, I mentioned early on the golden period, the first 5 years, it really doesn't matter when you take it because your body seems to store up the levodopa. So the levodopa gets converted into dopamine and it remains there for use later on. So you can take it every 8 hours, or you could take it before breakfast, lunch, and dinner during the daytime, and it really wouldn't matter. Now, when you get into advancing Parkinson's disease, that's a different story, and you're going to become more careful about when you take it. And I think somebody asked, how long before a meal or how long after? It usually takes about 30 minutes for the medicine to be absorbed for the most part. I tell people 60 minutes, so they'll at least do 30 minutes. So it's my hedge against people's natural tendency to cut corners. So if I say 30 minutes, then they're going to go down to 50 minutes, right? 15 minutes. 2 hours afterwards, you really need 2 hours to clear all the protein out of your gut. So that's the general window. But again, there's 1 out of 5 people, it doesn't matter if they take it with food or not. So if you happen to be one of those lucky people, don't worry about it. All right. Going on. Immediate release versus sustained release. And this is the old Sinemet CR, which I call Sinemet crummy release or erratic release, and this is why. Controlled release is less predictable. It's less bioavailable, so if you take a dose, only 70% will be absorbed. The problem is that 70% is an average. It ranges from about 0% all the way up to 100%. And that varies from dose to dose. So when you take a dose, you might not get any of it, or you might get 70%, or you might get 30%, or you might get 100%. So you can never tell with Sinemet CR how much you're going to get out of it. So very variable. And then it has very complicated interactions with dietary protein and gastric emptying. So managing with Sinemet CR is generally problematic, especially for somebody that's already having fluctuations. So the immediate release pill is a lot easier to adjust. You can't break the Sinemet CR tablet in half because it becomes not a CR tablet, a controlled release tablet. The immediate release has a more shorter predictable time to onset. If we look at dyskinesia and motor fluctuation frequency, comparing people that started with immediate versus sustained release, they're the same. So there's no advantage of warding off motor complications. CR may have a little bit longer duration, anywhere from 30 to 90 minutes. The only time I use CR is to get people overnight with some medication. Some people have wearing off overnight, and this is a decent approach to getting somebody some medication overnight. If it doesn't work perfectly, it's okay, they're asleep, so it's not going to make that much of a difference. But during the daytime, I generally do not use controlled release. Another way to increase dopamine is to not make more dopamine, but prevent its metabolism, and that's by blocking the main route of metabolism of dopamine, which is monoamine oxidase B. So in normal aging and Parkinson's disease, the activity of monoamine oxidase B goes up and starts chewing up more of your dopamine, and consequently your dopamine levels go down. So if you block this enzyme, monoamine oxidase B, the dopamine you're making stays around longer. That's how these medications work. And so this is a medication called Rasagiline, which is a monoamine oxidase inhibitor. Again, this is that golf score, UPDRS, so lower score is better, higher score is worse. The dotted line are people that were placed on placebo, and by the end of 26 weeks, they got about 16% worse. People that were on Azilect got better, not as better as what you saw with Levodopa, of course, but they got better. And that persisted all the way out for the first 26 weeks. So eventually the disease progression will return, but you see you bought yourself at least half a year of time where you're kind of keeping things even in terms of your symptoms, which is, I think, of value. Dopamine agonists can also be used as initial treatment. Of the advantage here is they bypass the presynaptic dopamine neuron. The advantage over levodopa is they have a longer duration of action, so they can really smooth out fluctuations, and we'll talk about that later on. Recall, since they generally only bind to one of the two dopamine receptors, they're generally less effective when compared to levodopa. They have many of the same side effects: nausea, lightheadedness when you stand up, that's called orthostatic hypotension, hallucinations, somnolence, and this unique one to dopamine agonist is leg swelling. So dopamine agonists, unlike levodopa, can cause leg swelling. The hallucination rate is much higher in dopamine agonists. So for example, the dopamine agonist hallucination rate is around 15 to 17%. For people on levodopa, it's around 3 to 5%. So if you're worried about causing hallucinations, this class of medication tends to cause more of that. Another thing that can happen with some people taking dopamine agonists is compulsive behaviors. This is compulsive, new, abnormal behaviors that are repetitive and bothersome or disruptive to your social or family life. So if it's something you've done all your life and it's not a negative thing, then it's probably not from the medication. But if all of a sudden you start gambling, you've lost the family finances, yeah, that's a problem. Some people think that use of dopamine agonists first reduces the risk of dyskinesia, and here's why. There's a couple of studies that show this exact same thing. This is a study where they compared people with very early mild Parkinson's disease, and they were randomized to two groups: people that were taking levodopa alone, or people that were started on ropinirole and later they added in levodopa. And this is the probability of remaining free of dyskinesia. So people on levodopa alone develop dyskinesias more rapidly than the people that started initially on ropinirole. This study has been repeated with pramipexole as well. So this is fairly convincing data that, yeah, agonists do look like they slow down the rate of development of dyskinesia. You got to bear in mind, though, this is all dyskinesia. A lot of people that have dyskinesia are not bothered by them at all and often don't even know that they're having dyskinesia. So you have to take that into consideration when interpreting that data. The other thing with agonists, because of their higher propensity to cause side effects, you really need to be cautious in starting and titrating the medication. So the idea is you start low and you go slow. For pramipexole, I generally start off at 0.125 milligrams 3 times a day. And it takes me about 9 to 12 weeks to get up to a dose that's just going to be in the starting range where it's actually doing something. Same thing with ropinirole. It takes a long time to start at 0.25 milligrams a day and get to the average dose, which is 13.5 milligrams a day. Again, you're talking 3 months till you get to the minimum dose that's going to start improving symptoms. So the mistake I see a lot of docs make is they use these dopamine agonists, they start at this low dose, and they go maybe a quarter of the way to getting to the average dose that works, and then they stop because the medication's ineffective. Well, it's ineffective because you haven't gotten to an effective dose yet. Compare that to levodopa. It will generally take me about 3 to 4 weeks to get to somebody to an effective dose range with levodopa. So a little bit easier to adjust levodopa than the dopamine agonists, but they still work fairly well. Other adjunctive therapies I didn't spend a lot of time on. Anticholinergics can be used. Trihexyphenidyl and benztropine, they tend to be low in efficacy and high in side effects. Side effects like dry mouth, blurred vision, trouble thinking, can't urinate, constipation, lots of fun stuff. And the side effect rate is usually fairly high. Some people feel that anticholinergics may be helpful for people that have tremor-predominant Parkinson's disease. I briefly touched on amantadine. Again, it has a low efficacy in terms of improving the symptoms of Parkinson's disease. It causes the release of dopamine and blocks this receptor called NMDA. The second part of the activity of amantadine makes it very useful in suppressing dyskinesias, and we'll talk a bit about that later on. Lastly, Selegiline is another monoamine oxidase inhibitor that I don't tend to use much. It is metabolized to methamphetamine, which may have some adverse effects like insomnia. And may augment the effects of levodopa, which would be a benefit. There was a lot of interest in Selegiline about 15 or 20 years ago because there was early results from a study that suggested it may slow down progression. But it turned out the study design was confounded, and we really couldn't interpret the results of the study effectively. So we don't really know whether Selegiline slows down the progression of the disease or not. So, boy, what do? We got lots of good choices, and that's what I tell patients. You got lots of good choices. None of these are really going to be bad choices, and nearly every one of these is going to work for you. But you have to compare in your individual case. This is where the physician-patient communication becomes very important. What's important to you? Controlling the symptoms or avoiding side effects, for example. Is it more important for you to have to take a medication that you only have to take once a day, or that you have to take 3 times a day? Is it more important for you to be able to get to a dose that works in a short period of time, or can you wait 3 or 4 months for you to get to a dose that works? So all these things are things you need to understand and be able to discuss with your physician to arrive at a decision that's best for you as the patient. Now I'm going to give you my personal strategy, and if you ask Dr. Cullis or Dr. LeWitt or Dr. George, they're going to tell you something completely different, because there's a different way to approach this, and this is how I was trained, and this is how I do things, and they have reasons for doing what they do. But if somebody has very young onset Parkinson's disease, I'm going to arbitrarily define that as less than 50 years old, realizing that biologic age and chronologic age are not always the same thing. I usually start with either Rasagiline or a dopamine agonist as monotherapy because these patients tend to develop a lot of motor complications, and these 2 drugs tend to cause fewer motor complications. If somebody's over the age of 70, I become more worried about side effects like hallucinations. I think that's higher in aged patients. And people with older onset Parkinson's disease tend to get fewer dyskinesias, so I'm a little less worried about that. If they have minimal symptoms, I'll use Rasagiline. If they have symptoms that are really keeping them out of what they want to do, I'll start with carbidopa, levodopa as my initial therapy. Now, fortunately, this is where most of the people lie. Usually when people come to me, they're in this range of 50 to 7 years old, and this is where I tell them, you don't have a bad choice. You have 3 really good choices. And if you choose one and you don't like that, you have 2 other good choices. So you're in a really good situation here. So don't fret too much about which decision you're going to make because they're all going to work, but you have to weigh in the factors that I mentioned. So that's initial treatment. The second issue is after you've been on treatment for, let's say, 5 to 10 years and things aren't going well. Gee, Dr. Goudreau, you've lost your touch. Medications aren't working anymore. You don't know what you're doing anymore, Dr. Goudreau. I'm going to go see another doctor. Why aren't my medications working well anymore? So there's a lot of explanations for that. Well, it's a progressive disease. It gets worse by its nature. That's what it's going to do. And if you look at the symptoms that are measured in the off state when the medication's not on board, those clearly get worse over time. The other thing is people develop treatment refractory symptoms that no medication will treat, at least the ones that we have to treat motor function. And those tend to be symptoms that affect the midline or middle part of your body, and those are things like memory, mood, speech, swallowing, certain aspects of balance, bladder control, constipation, temperature regulation. These things can be quite disabling, and they don't respond to changing dopamine medication. We need new treatments for those midline treatment refractory symptoms. A lot of these symptoms are non-motor symptoms, and changing drugs that are designed to impact the motor symptoms is not going to affect the non-motor symptoms. Also, have to bear in mind if somebody has a systemic illness for a variety of reasons, Parkinson's will get worse. So if you get a bladder infection, your Parkinson's will get worse temporarily. If you have a heart attack, your Parkinson's symptoms will get worse temporarily. If you fracture your hip, your Parkinson's symptoms will get worse temporarily. So always have to bear in mind that if somebody's suddenly gotten worse, it's probably not Parkinson's disease that's causing that problem. It's some other thing going on. Now we're going to spend a little bit of time talking about motor complications, and that's something that we have a lot of things we can do with medications to help out with. And let me explain that by showing the following graphs that breaks down people in this golden period, the first 5 years, the next 5 years, 6 to 10 years, and then greater than 11 years. And up top are graphs that show The clinical effect of levodopa, which is this white arrow, over time, it also is the amount of levodopa or dopamine that's in your brain. So early on in Parkinson's disease, you have this thing called the long duration response. So you take a dose of levodopa, it builds up in the brain and makes the dopamine in the brain go above this response threshold, and your brain stores up that dopamine, and it remains above the response threshold for a very long period of time. And then we call that the long duration response. That's why you can take the medication virtually any time of the day and you don't notice it wearing off. In fact, sometimes people make the mistake of, gee, I skipped a dose and I didn't notice I got worse. Maybe the levodopa is not doing anything. Well, the main reason early on that it's probably you didn't noticing because you got this long duration response. People early on often don't have any dyskinesias or have a low rate of dyskinesias. As the disease progresses in time, 6 to 10 years, you develop this thing called the short duration response. So what happens is you just take the same dose of levodopa and the brain concentrations of dopamine rise and fall now. They don't stay up. So you have this finite period of time that you spend above this yellow dotted line or response threshold. Generally, this is about 2 to 3 hours for most patients. And so you have to be very careful about when you take the dose of medication. You usually end up having to take the medicine every 2 to 3 hours to make it work properly. And then you start getting this thing called dyskinesias, which is this red dotted line. So if you think about early on in the first 5 years, the threshold for getting dyskinesias is so high that you never reach it. But as the disease progresses, the dyskinesia threshold tends to get lower and lower and lower and lower. And now when you take doses of levodopa that work, you start getting dyskinesias, especially in advanced Parkinson's disease. Now anytime you take a dose that works, sure, you get above this yellow dotted line and improve for 2 or 3 hours, but you also go across this red line and you get dyskinesias with every dose that you take. And that typifies advanced Parkinson's disease. So how common are these things called motor fluctuations? And this is a graph that shows on-off motor fluctuations in yellow and dyskinesias in red. These are people that have taken levodopa for 1 year. So motor fluctuations are about 15% after 1 year and about 40% after 1 year for dyskinesias. And by 9 to 15 years, almost everybody has some kind of dyskinesia and almost everybody has an on-off effect. So this is inevitable in a vast majority of patients. Fortunately, we have a lot of strategies to help out with this. And again, just like early treatment, we're in a good situation unlike a lot of other neurologic diseases like Alzheimer's disease, Lou Gehrig's disease, where there's really not any remarkably effective treatments. We have things we can do about this. So what can we do? Well, what we call these manifestations are especially the short duration response. We look for the loss of the long duration response where people wear off after 2 to 3 hours. Sometimes it happens abruptly. Sometimes people take doses that don't seem to work at all. So I took 1 dose of levodopa, and then the next dose I took, it didn't do anything. And then a lot of times people, after they've gone the whole evening or overnight without taking medication, they're very stiff and slow and have difficulty getting started in the morning, and we call that early morning off. So these are all manifestations of these things called short duration responses. So what's the easiest way to deal with short duration responses? One easy way to do it is called dose fractionation. So this is a typical profile of somebody taking carbidopa, levodopa 4 times a day. So they take a dose here, dose here, dose here, dose here. The plasma concentrations and brain concentrations of dopamine go up and down like a sawtooth. If you're in this yellow area, your symptoms are improved. If you're below it, your symptoms are not improved, that you're stiff and slow. If you're above the yellow area, you have dyskinesia. So a lot of people spend their day like this, where they're cycling between being off, stiff, slow, shaking, doing pretty well, and then having dyskinesias, and then the medicine wears off and the cycle repeats itself. One way to address this without starting a new medication is just use smaller doses of levodopa more frequently. So in this case, instead of taking the medication 4 times a day, you could go up to 6 times a day and take the medication more frequently. Of course, that becomes a little bit more inconvenient, taking the medication that frequently. It may not be easy to remember taking it, so you might have to rely on the use of a timer, often very simply just getting a small plastic box that you put your levodopa tablets in, find a simple egg timer that counts down from like 2 hours. Let's say you're taking it every 2 hours. You glue that on there with some crazy glue, put that in your pocket, and set it for 2 hours, and go, it beeps at you. Open it up, take your pill, close it back up, hit reset, and it counts down another 2 hours. That way you're not looking at the clock all the time. Now you can buy fancy ones at the pharmacy that cost you, $20, $30, but you could probably make one for $5, I bet. And but you can't keep your pills inside your smartphone, at least as far as I know. It can, yeah, you can program your phone to remind you to take it. But I'm trying to think of something really simple. that you could go to the Five and Below store and build yourself for $5 as opposed to buying at the pharmacy for much more. All right, what can you do otherwise other than dose fractionation? Well, you can give a longer-acting medication. That's where these dopamine agonists become incredibly effective. Ropinirole, pramipexole have long-acting forms that last 24 hours. Rotigotine is a patch that lasts for 24 hours. Really great in smoothing out responses. You can give drugs that block the metabolism of levodopa, like tocopone and entacapone. You can give things that inhibit the metabolism of dopamine, like Rasagiline and Sinemet. This is a newer comer to the market, the carbidopa levodopa intestinal gel. So it's the same drug, put in a gel. There's a tube that's inserted through the skin into the intestine, and the pump runs for 16 hours continuously and delivers a nice continuous amount of levodopa. And then finally, I mentioned Rytari, a very clever formulation of carbidopa levodopa, where you have this combination of shorter, medium, and long-acting beads, and then this powder that's really fast-acting. So you get the fast-acting part of the levodopa, but you get a longer duration of response as well. This tends to be, or appears to be, more consistent than the old Sinemet CR. So again, when you're adding on therapies like a monoamine oxidase inhibitor or a COMT inhibitor, you got somebody that's taking 3 doses a day. They don't want to go to 4 or 6 doses a day. What can you do? Well, you can give something that prevents the metabolism of dopamine or levodopa. And you can raise the amount of medication that remains in the body. You get less off time and improved on time. And that's generally what you see with these approaches. So again, you think about dopamine. What happens to dopamine? Well, it can be metabolized by this thing called monoamine oxidase B, and you can block that. Or dopamine can also be metabolized by this other enzyme called COMT. Levodopa itself can also be metabolized by COMT. And if you give inhibitors of that, you can prolong the action of those medications. The dopamine transdermal system is nice. It produces a 24-hour sustained thing. You do have to apply the patch daily. The patch has to adhere. You have to move where the patch is applied to. There's long-acting once-daily formulations of pramipexole and ropinirole. I mentioned the gel. I think somebody had talked previously about the subcutaneous apomorphine pump, not yet available in the United States, but you can get it in Europe. And then people are developing new ways of making levodopa last longer. And one is this clever accordion pill. When you take it, it slowly unfolds in the stomach, and each time it unfolds, it releases a little bit of levodopa, so you can have a longer duration of response from a single drug administration. All right, what about the sudden wearing off? And this can be really bothersome to people when you're going along just fine and the floor drops out from underneath you and you can't move. What can you do for that? Well, simply you can use a rescue oral dose of carbidopa levodopa. And what you do is you take whatever you're taking for your normal daily dose, you crush that up and dissolve it in a half of a glass of juice or pop, soda if you're not from Michigan. And then not all of that will dissolve. There'll be some stuff suspended in there, but most of the drug will dissolve. You take that, it should start working fairly rapidly as a rescue medication. It doesn't require a new prescription. They do make a subcutaneous injection that you can be trained to use, or you have to have a caregiver administer it, because if you're off suddenly, you're not going to get an injector out and inject yourself. So you have to have somebody that's around that can help you. And then under development are other things like sublingual administration of apomorphine, a little wafer that you stick under your tongue that dissolves and absorbed under the tongue, and then an inhaler with levodopa that provides supposedly a pretty fast response. So these things should be available hopefully soon as rescue approaches for sudden wearing off. All right, the last thing I'm going to talk about is the dyskinesias that come on in Parkinson's disease. Remember that dyskinesias frequently are not bothersome to patients. So one study showed probably about 80 to 90% of dyskinesias are not bothersome or are easily fixed with simple changes in medication. So a lot of times people have dyskinesias, you ask them, is that bothering you? And they're not even aware that they're doing it. The only person that it bothers is the family member or the caregiver or the physician. So you got to bear that in mind, that dyskinesias don't always need to be treated. But if they are causing disability, embarrassment, social withdrawal, throwing you off balance, preventing you from doing things, sure, they need to be treated. So what do you do about these involuntary movements? Again, this is a graph showing all comers, the incidence of dyskinesia over time on levodopa therapy. So this is 7 to 12 months over here, it's about 7%. But again, by the time people have been on levodopa or have the disease for about 9 to 15 years, it becomes quite high. This usually represents an excessive medication effect. It tends to be dose dependent, so the higher dose of levodopa or dopamine agonist, the more likely these are to occur. The converse is also true. If you lower the dose of dopamine medication, the dyskinesias usually go away, and that's the easiest first approach to getting rid of dyskinesias. But the problem is, sometimes when you lower the dose, you lose control of the Parkinson's symptoms, and then you're kind of stuck. What do you do then? We have a couple of things we can try. So again, the first thing we try to do is reduce the dose of levodopa or the dopamine agonist. If people are taking Sinemet CR, sometimes they come on to me saying they're taking Sinemet CR, and it's just too unpredictable to use in somebody that's fluctuating. So I usually get rid of that and change them over to immediate release. You can use adjunctive treatments like amantadine. Amantadine is very nice. It suppresses dyskinesias. The dose I generally use is 100 to 200 milligrams twice a day. Be careful of amantadine taken too late in the day. It can keep you awake at night. So I generally tell people take it first thing in the morning and maybe about 1 or 2 o'clock. Don't take it after 4 p.m. It's like drinking a pot of coffee, in the evening. It's not going to work out for sleep very well. Propranolol has been reported to work to suppress dyskinesias. I've tried this several times, haven't found it to work. People that have really bothersome dyskinesias, I think, are the great candidates for deep brain stimulation. Does a nice job of taking those away. There's a lot of drugs under study to suppress dyskinesias that may be available within the next few years. Now, last thing that I'm going to talk about is hospitalization. And most of us who manage Parkinson's disease patients or have family members or loved ones who have Parkinson's disease have easily recognized this phenomenon. Whenever people go into the hospital, they have Parkinson's disease, they always do worse. Why is that? I mean, it's consistent. They do worse. And it's just, you expect you're going to do worse when you get in the hospital afterwards. Well, these are what you would hope would go on when you get into the hospital. So this is the myth that, they're going to call my neurologist to make sure that I'm on the right treatments, right? The pharmacy will have all the Parkinson's medications that I normally take. The nursing staff will understand that I have Parkinson's disease and I can look great 1 minute and then 30 minutes later and look terribly disabled and I'm not faking it. I'll get my medications on time. And all the physicians that take care of you will know all the drugs to avoid giving you that will make your Parkinson's worse. So you can easily see, and I heard a lot of people laughing, that these are all myths and they're not true. All these things, the exact opposite is true. So these are the data. 3 out of 4 people with Parkinson's disease that get in the hospital do not receive their medications on time. So that's 75% don't get their medications on time. Of those people that don't get their medications on time, 61% of them have serious complications from not getting their medications on time. This is a huge, huge, huge problem, and we got to fix this. You think it's a tractable problem, you think it would be easy to fix, but we have to work together as a community to fix this. Because it won't be just me arguing about it, and it won't be just you arguing about it, it's everybody together. So people with Parkinson's disease are hospitalized 50% more than people without Parkinson's disease. People with Parkinson's disease suffer avoidable complications at a higher rate than non-Parkinson's patients. What this results in is longer hospital stays and a 44% higher adjusted risk for mortality. Yeah, I'm nearly done, so that's going to work out well, and I'm glad you held up the sign. So why is this happening? Well, I think people don't understand Parkinson's disease. We need to educate them, even in the very best hospitals in the United States. So this data that they collected even included the very best hospitals in the United States. So it's just not the community hospitals that are making mistakes, it's everybody. There's lack of awareness about the critical importance of getting medications on time. There's lack of awareness that many common medications used in the hospital for pain, nausea, depression, and psychosis are not safe to use in Parkinson's disease. Hospital pharmacies often don't stock the full array of Parkinson's medicine. And lack of awareness that poorly managed Parkinson's disease can result in mental confusion and other serious complications. So what can we do about this? Well, there's 2 programs, one in the UK and Canada called Get It On Time, and you can find that online. And then this is from National Parkinson's Foundation called Aware and Care, and you can obtain the package of information that can help blister people with information when you get into the hospital about the importance of these issues. And then making sure that your physician and you're doing all you can, and I'm doing all you can to help the hospital policy change to allow patients and caregivers to administer home medications in select cases. I finally got that done at one of our hospitals in town here. Yeah, we can do that now. That's been a recent thing that's changed over the last year. But in certain circumstances, of course, if somebody doesn't have a care provider, he can't do it, doesn't have the mental capacity, they won't allow that. Also, convincing hospital pharmacies to carry all the full array of Parkinson's medications, which shouldn't happen. And if you have any other suggestions, please let us know, because we really need to fix this. It should be a solvable problem. Again, summary. So there's effective treatments for initial Parkinson's disease, and that's the silver lining to Parkinson's disease. We can do a great job of managing the symptoms. Motor complications are common in advancing Parkinson's disease, but manageable for most patients. Symptomatic treatment options need to be tailored to the individual, and what you can do to help your doctor is understand how these drugs work and what their advantages and disadvantages are. And then work with us to improve the care of hospitalized Parkinson's disease, because right now they're in peril. I mean, people do worse, and that needs to change. Thank you.